Excuse me, ladies and gentlemen. Thank you for your patience in holding. We now have your presenters in conference. Please be aware each of your lines is in a listen-only mode. You may submit your questions electronically anytime by using the Q&A pod located to the right of your webinar platform. You may also download a copy of today's slides using the Files pod located below the slide presentation. It is now my pleasure to turn the conference over to today's first presenter, Mitul Patel. Please go ahead.
Thank you so much for that setup and introduction. Good day, everyone. My name is Mitul Patel. I am Senior Director of Innovation Programs and Services at the American Hospital Association Center for Health Innovation. I am honored to be your moderator today for the webinar. Before we jump into the good stuff, a couple housekeeping notes. The webinar is being recorded, so you'll get an email once that recording is made available. Just so you hear it again, the Q&A pod is located to the right of the screen there. So if you have a question, please submit your question there. We do have some time for Q&A at the end of the session, so we're trying to get to as many questions that you have as possible. And yeah, the PowerPoint is located in the Files pod, which is right below the presentation as well. All right, so let's get to the good stuff here. It's my pleasure to introduce you to today's webinar, which is a team approach to improving the acoustical environment, which is brought to us by our good friends at the Healthcare Transformation Services Group at Philips. And we have two expert speakers for you today, Lisa Paul and John Davanzo. Lisa is a recognized expert in alarm fatigue and alarm management. She's a member of the AAMI Healthcare Technology Safety Institute's National Clinical Alarms Steering Committee, and often presents on alarm management. Her clinical expertise spans adult critical care, NICU, PICU, telemetry, the ED, the OR, and the PACU. And past nursing positions include critical care, telemetry, step down, in the med-surg unit, float pool, home health, so all over for Lisa. She's also the principal and practice operations lead for the acute care consulting team. John is an expert in hospital operations, workflow, and process redesign. He's a consulting manager in the Philips HTS with the acute and critical care and performance improvement team. He's a number of projects on telemetry optimization. He's also a fellow in the American College of Healthcare Executives. He is a regular presenter on various topics, including healthcare efficiency and the use of simulation in healthcare. His clinical expertise includes emergency care, pre-hospital care, pediatric, and adult ICU. So we're in great experienced hands here, folks. And with that, I'll turn that over to Lisa and John. Thank you.
Thank you very much for that introduction, and thank you everyone for joining us. This is Lisa, and just very quickly the objectives today at the end. You can see them on here. I won't read them exactly, but really be able to talk about the acoustical environment and noise and what hospital soundscape actually means. Identify some of the potential negative impacts of noise both on staff and patients. Really understand what the goals of a sound management strategy are and how you can refine those, and how to utilize the Cocreate methodology and champion program as you're working on your sound management strategy, and even identify some key metrics and KPIs that you can use to try and evaluate the impact of the noise reduction strategy. The contents are over there, but we'll go ahead and move on and talk at first about noise, the acoustical environment, and soundscape very briefly. I think if you're a nurse, you're familiar with Florence Nightingale, and she actually wrote Notes on Nursing back in 1859, and in there she actually talked about noise, identifying it as the most cruel abuse of care, which can be inflicted on not just the sick, but also the well, and she talks about unnecessary noise. So what is noise and who decides when we're talking about unnecessary noise? If you actually look at the Wikipedia definition on the bottom, you'll see pretty simply it's unwanted sound that's judged to be unpleasant, loud, or disruptive. So it is that subjective component, but if you look at the definition above, which is actually from the EPA, the Environmental Protection Agency, it takes it a step further. It's actually saying it's any sound that can produce physiological or psychological negative effects or undesired effects. And that's really more what we're interested in, is the impact it has on our patients and staff. So when we talk about the acoustical environment, it is really the sound environment in a particular physical space that you're at. And the hospital soundscape takes it a little bit further. And again, we'll talk about the difference. So the Oxford definition on the bottom talks about the soundscape as really being sounds heard in a particular location and considered as a whole. And so keep that in mind, because it's talking about both good sounds and bad sounds, or those perceived as noise. If you look at the definition above by the International Organization for Standardization, it is talking about perception again and how it's experienced and or understood by a person or people in context. So it's more that situation and what's happening in the situation. So what are some sources and impacts of noise in the hospital environment? There was a study done that showed that there were 86 different sources of noise they identified in the hospital. You see some of those on here, not all of them, and I'm sure you could fill in some additional ones on here too. But things like monitoring alarms, staff talking, other patients, and other devices. It's also interesting to note, and no surprise, that the average sound levels have increased since 1960, and they went up, and we'll talk about that even a little bit more in the next slide, but note that this study was actually done in 2005, so I think if we would redo this, the sound levels would be even higher. So when we talk about sound levels and perception, you can see on here different measurements. And what you'll see in the middle is 60, and just as a reference, that's typically the level for ordinary conversation. What you'll see above that is where sound levels used to be during the daytime back in the 60s, which was 57. Again, when that study was done in 2005, it jumped up to 72, and for nighttime, you can see that it was 42, and it has jumped up to 60. Now, to compare that, you'll also see between 40 and 50 the number 45, which is actually what's recommended in the guidelines from both the EPA and the American Academy of Pediatrics. So you can see we're well above those already. You'll also see on the top, ICU alarms typically start at about 70 decibels and can go much higher, as can other device alarms. And you'll also notice on the end above that 16x that one study actually measured decibel levels at 100 during change of shift report in an ED. So that was the staff talking. And the last thing to keep in mind here is that decibel measurements are logarithmic. So any 10 decibel increase from a perception perspective is like doubling the noise or sound level, and a 10 decibel decrease is essentially halving it. You can also see below some common items that sound occurs or generates and relates to. So for instance, you can see when we're talking about that 100 decibels, that correlates to a lawnmower. Pretty loud. So what are some of the potential effects of noise? Research has been going on this for a long time, and there is a lot documented in terms of the impact on patients, both in terms of blood pressure going up, heart rate going up, but a lot more looking at the impact it's also having on sleep and the impact lack of sleep can have on patients. For staff, it does cause stress and fatigue and can hamper communication. It's also interesting to note we tend to think of noise occurring kind of in the moment, but another study has found that noise can have a cumulative effect for hospitalized patients over several nights so that they start to feel trapped in a stress-inducing soundscape, which can actually lead them to want to leave the hospital early and have problems with their recovery. One other study found again that noise interferes with the attending a resident interaction in more than a third of shift change communication. We'll also talk just a little bit more about noise and sleep. There are some organizations that are taking a closer look at this, and one was an informal group called Hypnos. They had a multidisciplinary symposium in 2017. where they were looking at the hospital soundscape and really trying to look at it from a holistic perspective, not just the negative effects, but what are the positive effects in terms of the soundscape. They are looking to test interventions and hopefully will publish more. In addition, clinical practice guidelines that came out in 2018, referred to as PADIS, really added sleep disruption and also talked about delirium. They do recognize more research needs to be done, especially on the impact of using noise and light reduction strategies to help promote sleep. And again, what that potential sleep disruption impact has on delirium. So lots of negative effects when we talk about noise, but where do you start? Because there are so many things, again, as we've talked about, that generate noise in the hospital. And one of the places typically is medical device alarms. They do present one of the biggest challenges. They've been identified by ECRI, who is a nonprofit organization focused on device safety, and they produced the top 10 technology hazards, and in 2020, number 6 was alarm alert and notification overload. So that's a good place to start. I think it's fairly well known now that 85 to 99% of alarms are considered non-actionable. There have been negative patient events, including deaths that have occurred, and the impact just on monitoring alarms alone. It was apparent in a study done by Barbara Drew where 5 ICUs had 2.5 million monitoring alarms in 31 days. That comes out to about 30 million alarms in a year occurring in a hospital just in those areas and just monitoring. So really want to look at reducing non-actionable alarms, alerts, and notifications to help improve patient safety, to try and standardize, and of course to reduce noise. So let's talk about where teams fit into this a little bit more. Because if you want to focus on a particular area, and a lot of our case studies right now are going to be around alarms, alerts, and other notifications, you do need to have a team approach, and you want to use a multidisciplinary team. And you really need to look at what resources you need. So trying to identify what you're going to focus on first. In this case, if it's alarms, alerts, and notifications, will help identify who we need on our team, but also look at it from a permanent or an ad hoc basis as well. So who's going to be the core of the team and who will be people that you pull in as needed. Typically, you do want a corporate sponsor, so any of those C-suite levels who will essentially provide a little heft to it throughout the organization, saying this does have corporate support, and they can also help if there are roadblocks that need to be removed. But then looking at not just nurse managers, where we typically tend to go, but also providers, frontline staff, including ancillary staff, like monitor techs or PCTs, who may be involved in either responding to alarms or getting notifications or alerts as well. Pharmacists, if you're looking at IV pumps, even patients and families. We tend to rely on surveys, but it's really good to do focus groups and even have them as ad hoc members to give their view and opinion on what is considered noise and what would be helpful. After you've done that, you really need to look at your team goal. So short term, it is to reduce noise. That's the usual starting point. And again, really defining that. So in this case, to reduce non-actionable alarms, alerts, notifications, and unnecessary noise in order to improve patient safety, patient care, patient and staff satisfaction, and really ensure actionable alarms or alerts can be heard and responded to and appropriately take action. So here's where your team also needs to work together to start defining and agreeing what do we consider actionable alarms, alerts, notifications, what do we consider non-actionable. This is an example at some of the places where we've worked, and you can see on here things like life-threatening alarms are those that require an immediate response and action, and that is considered actionable. Whereas non-actionable can be self-correcting alarms like SpO2 alarms, or where you're actually doing something that you know you'll trigger it. But it's really important for the team to have a good conversation on this and come to an agreement so everybody is on the same page. In addition, start looking at long-term goals. So initially we reduce noise. That's sort of the easiest, but we really want to effectively manage sound from a holistic perspective. And I like this because it is a kid's game as far as playing telephone. But you can see where they're trying to reduce noise by the hand over the ear, where they're also trying to hear relevant sounds by having the can pushed really close to the ear, and the HIPAA compliance on the other end, where the little boy in red is really trying to ensure he's got his hands kept around there, that only the little boy in green is hearing what he has to say. And then speech intelligibility, the actually being able to understand what's being said, and that's a key piece. And the only piece that doesn't show on here is then using positive sounds, things like music, to also help create a more soothing environment. And I'm going to hand this over now to John, who will talk a little bit about how your team and others can do a current state assessment.
Thanks, Lisa. So we are going to talk for just a minute about our current state assessment, and this is the model that we use as part of HTS. And the beauty of this model is it really can be modified for various projects. But we look at a number of things, and we start with data analysis. In this case, we were talking about alarms and alerts, so this one is actually built for that model. So we'd look at alarms and alert data. We'd look at HCAP survey scores. Then we go on to looking at people and interviewing key stakeholders, people that are involved in the process, staff, and then we also start to look at observations of the actual care process, and whether that's shadowing staff or tracer type work, that's how we would get that information. Then it's an analysis of process and end-to-end process from the patient arriving on a unit or arriving in the hospital and looking at, in this case, all of their monitoring and alert notification, through all of the workflows, all the way to the point where they are discharged. We evaluate technology, and in this case, it could be Philips technology, but truly my team is device agnostic. It could be other technology. We look at nurse call systems, IV pumps, things along that line. And in this case, all of those make noise and alerts and alarms, for the staff that's there. And then finally, and Lisa just kind of alluded to this a little bit, when you're putting together your multidisciplinary team, that's also part of your culture. How does that culture, that team work together, and how do they make decisions? And as part of that, we also look at onboarding and event reporting. So when we look at data analytics, we start out looking at a baseline, and these are just some examples of things that we have done, and then if we make changes, we look for some quick wins, but then if we make changes or we pilot, a new process or a change in alarms and alerts, then we want to impact, or we want to look at the impact of those changes. So, and then finally, once we kind of hone in on, what we want done across the board, maybe in like units or a whole hospital, we want to monitor that to make sure that we sustain those changes. And those three steps, are going to be common to any kind of pilot initiative that you would do. So just kind of looking at some alarm and noise data, in this case, you're looking at, some IV alarms, and then some sound loggings as well. And in this particular case, one of the things that we found out was that IV alarms were the loudest in the patient rooms when we looked at the sound levels. So even though, your staff or you think about that and that's not the first thing that jumps to your mind, it is one of the first things that jumps to your patient's minds. So this is making sure that you're encompassing, all of those systems that you have together. Think about nurse call as well. Those can be fairly loud. Now that goes the other way. Maybe your patient's not going to hear it quite as much. They hit the button, but certainly your staff, is hearing that as one of the loudest, alerts on the unit. So, we also, as we start, as nurses, any of you are nurses that have, mobile devices, the amount of data and notifications that are coming at you, every day, every hour, even down to every minute. And there's a balance here that needs to be struck, between safety and the amount of disruptions that you have. When, one example, in this case, we're looking at red alarms that are coming through a paging system. Depending on who's getting those, now I've got them coming from the central station, from the bedside, and I've also got them, coming to the nurse. And the question is, who needs to get those, how often, and how do we know that the response is, how do we know the response has been done? And we need to look again at pulling all those systems in, not necessarily just cardiac monitoring alerts. So when we look at all this data, really the reason it matters is the overall impact to your staff and your patients. In this, we're looking at, one unit over a 30-day period, having, a number of alarms. And if we work through, monitoring alarms, monitoring alarm alerts, and nurse call alerts, the average disruption, and this is a little bit of fuzzy math, but is about 2.2 disruptions per minute. Now you think about, a CNA who's trying to complete, a process, or a nurse who's trying to put together medications or trying to do an assessment on a patient, and you can see that the impact of that is fairly significant. So there's other data information that goes in here too, and that includes the patient. So, one of the HCAP survey questions, which I'm sure you are all very familiar with, is during this hospital stay, how often was the area around your room quiet at night? And, ambient noise, this is, in my experience, this is one of the most difficult areas to, impact overall. And per hospital, compare the national average response, for folks that reported it was quiet, is about 62%. So that's fairly low. And if you don't do a complete assessment of everything that's going into this, it's going to be very difficult to impact. So the next piece there that we had was people, process, and practice. And these are some quotes that we've gotten, from different assessments that we've done. Some of my favorites, the third one over there up at the top, I hear alarms in my head when I go home. I've had those evenings, and, if you look over, two things my mom complained about the most, the food and the alarms. Sorry to the folks in dietary, but, the fact that the alarms come up there is significant too. If I responded to every alert, I wouldn't get everything done. I mean, you can see, you can hear the frustration, behind these. And one of the things you need to do to be able to understand where this comes from is really, take a look at the entire process from end to end, and you see a workflow map down there for an alert. And we need to understand where those, gap points are and where we can make improvements in that. And so mapping the process, becomes very important. So as we, all of this kind of rolls up into some safety culture, how do we work? We need to understand the onboarding process. I was working, with a client a few weeks ago, and when I asked about their onboarding process, the first answer I got was a little bit strange. It was all kind of on the job. Well, we kind of backed that up, and the reason that it came out that way is they have a lot of this built into their computer-based learning and orientation, so we needed to understand that as well. Who makes the decision for how that's done? How often is, somebody's competency assessed? And then when we talk to risk management, near miss and event reporting, you want to know in your institution, is this, are any of these, near misses or event reporting pieces that are coming up related to this noise, these noise and alarms? And one good way to start testing some changes is if you have the ability to simulate that, looking at your technology and workflow. It's great to do a pilot. It's even better to start out with a simulation and see if the changes in your workflow are actually going to, do what you think they're going to do. And if you look at if you look at our assessment and findings recommendation, what this really becomes, is a continuous circle. This doesn't end. As we start to look at utilization and optimization, there with telemetry, and we work all the way around, this circle and look at all of those things, we will identify the challenges, but this becomes a PDSA loop as well. we are going to, what we find, and then we're going to try to improve again. And we're going to keep looking at these assessments over and over. Maybe not all of them are quite as deep as this, but we continue to look at that. So, Lisa, I'm going to hand it off to you to talk about where we would start with that with Cocreate.
Thanks, John. And so once you do your current state assessment, and we talked about a team being formed really to start taking a look at noise, and I do want to say what you call your team is up to you, but it can have different connotations. So we often hear of a task force that's being put together, and that typically is referencing kind of an urgent need, looking at something and trying to get something accomplished pretty quickly. And then more long-term, a committee that's in place that you've made some improvements, you want to continue making improvements and move on down the road. There are places that have noise committees. There are places that have alarm and noise. There are places that have technology where they also have noise under it. So it's figuring out where it fits best in your organization. But after you have the assessment, your core team needs to be a part of this Co-Create workshop. And really, we use this to help define the future state. It is based on design methodology, and there are 4 components you'll see: the discover, frame, ideate, and build. Discover is often used to really help define what the problem actually is, where we've done that. We're saying it's noise, but we are trying to figure out what noise are we focusing on, and again, what are we going to define that future state as. So what you want to accomplish in your Co-Create, and typically it's a work session. It can be anywhere from 4 hours to 8 hours. It depends on what you want to tackle, how many people you want to engage as well. So the initial goal of the workshop is really prioritization. John talked about you will have done the assessment and you'll have come up with improvement opportunities or recommendations. So as a team now, you really want to review those and prioritize those. After you've done that, you really want to identify which top 3, top 5, whatever the case may be, do you want to focus on and pilot and see what the impact is. Typically, you want to do incremental changes so you can really ensure whatever you're evaluating is the item that's having an impact. It gets a little bit more difficult if you're doing multiples at once. That's also why we recommend doing things on different units. That way you can do multiple pilots at the same time, but get a better idea of the impact. And then the impact analysis, evaluating after the pilots are done to see what the results were, and did it have the impact you expected? Did we actually see the results we were hoping for? Those key metrics that you want to look at as well. So how do you go about doing that? You are going to do a team activity. It involves individual input, but then it really involves team discussion and alignment ultimately at the end to identify where you're going to place everything essentially on this board. So you're looking at potential impact of an improvement, and is it low, is it high? And then what's the effort or feasibility to implement it? Some things can be pretty quick and easy to do. Others can be a little bit harder. So everybody really takes their sticky note of all the improvement opportunities you've identified, and you pick one you're going to start with, and everybody places it on the board. And you will see sticky notes all over the place. It's rare that everybody comes to agreement initially on their own in terms of perception where things lie. And so then you want to have that conversation about, okay, where are we going to actually come to a final agreement and alignment on where this goes? So that involves a lot of discussion, input, hearing each other's viewpoints, listening to experiences, listening to some of your subject matter experts, and making that final call. I do want to mention, too, in terms of the Co-Create, we talked about your core team being there, but this is also the time to pull in more people, in particular more frontline staff, so that they really feel like they are part of the decision-making process too, and that their voices have been heard. So after you've done this, you then want to move on to the pilot implementation, and John did reference this, the Plan, Do, Study, Act. And really the ultimate goal while we're doing the pilots is to ensure patient safety. So we do want to make sure we're communicating to everybody that that is a priority and that at any point in time if patient safety is a concern, that the pilot will be stopped while that's evaluated. In addition, you really want to outline what your pilot strategy is, and the reason for that is you want to ensure everybody is on the same page, that you've captured the information, that everybody sees it, whenever it gets updated, everybody on the team gets that information too. So depending on the pilot you want to do, you want to outline what the goals actually are. What are the resources you will need? It may be people beyond your team. Perhaps you need to do education and you want to get nursing education involved. And the units you're going to do, they had not been a part of the Cocreate. So identifying those. And who are the project owners? Because although you'll have a team, you very clearly want to identify for each pilot who the lead project owner is on that, who really is going to take ownership. If any approvals are needed in terms of doing the pilot, whatever you've identified, who do you need to get that from and how do you go about doing that? What activities do you need to complete as you're preparing for the pilot? And the key piece here, what metrics and KPIs in terms of data? Can it be alarm data pre and post? Can it be number of alerts pre and post? Can it be HCAP scores or surveys? What are you going to use and what are you actually going to measure? Making sure, again, you get the pre and the post on that. And then what's your actual implementation plan? So it's taking a little bit beyond the activities that need to be completed for the implementation, but the actual plan. Are you going to have a kickoff meeting? When are you going to start it? Who are you going to have at the kickoff meeting? And then the piece down here in terms of education, communication, and near-miss reporting. How are you going to communicate the pilot to everybody? So beyond your team who's actually working on this to the broader organization. And what will the timeline be? And I think when you're thinking about all this and the people you have on your team, you might even consider doing a RACI matrix, which is really looking at who's responsible, who's accountable, who do you need to consult, and who do you need to keep informed. Because you'll have different people involved in this who fall into each of those different categories. So keep that in mind as well, and something to think about doing with the core team to identify that. In addition, you do want to get feedback from the Cocreate itself and understand what the perception was. This is one that we did with a large medical center, and 100% of the respondents really felt it was helpful because they enjoyed thinking about the opportunity prioritization with colleagues and thought that was vital. Really getting full participation and consensus, and again, you'll see the word colleagues, so everybody feeling like we're working on this together. Everyone's opinions were heard and inputs counted, and the group really felt confident moving out of this, that they'd identified short-term and long-term team opportunities to help them achieve the future state. So the Cocreate is really designed to help with that initial, okay, here are findings again, we're going to prioritize, we're going to pilot. After the pilots, based on the impact analysis and the team reviewing and providing feedback and your long-term strategy, you're going to start talking about which things do we want to implement from a system perspective. And when you're starting to look at it from a system perspective, you also then want to start looking at a champion model. And it's important because, again, research has shown that usually change initiatives almost always rest on a multidisciplinary effort. So you've already had a multidisciplinary team in place, but now we're looking for that designation of champions who can really help with the change management and the adoption strategy. As you're looking at champions, really what you want them to be are role models. So in particular, we talk about culture, and part of culture is attitude. So you want people who are positive and who are really going to help with this. They have the skills, they're the subject matter experts. Usually we have to help them get there, but that's part of the champion program. They're peer mentors, so frontline people who are going to be working with their peers, who the peers trust, look up to. They can identify problems while they're out there working, and they can also provide and function as a resource. and of course the change agents to really help ensure adoptions of new behaviors and still identify any potential roadblocks or barriers that may be in place that may be keeping others from changing their behaviors and doing what needs to be done, and also monitoring metrics. Again, this is an Alarm Champion program that we put in place at a large academic medical center. And you can see we planned, we educated with the outcomes of the actual champion education and then the ongoing plan. So it was outlining expectations, and this is really up to you as an organization and you determining what those expectations are, identifying criteria for your champions and what the oversight and structure will be of the champion program, what education needs to occur, select and get a agreement from the people you've identified as champions, and also identify what the evaluation process will be. And then doing the education, which was a combination of Philips providing education on the technology and the alarming capability in more detail for this particular group and having equipment on hand. And then it was also the site. There are people there identifying what the goal was of the Champion program, what their current policies and procedures were that impacted that, what the expectations were of leadership as well in terms of managing alarms, and for the champion role. Outcome, we had 4 8-hour classes, 45 staff educated, 34 from adults, 11 from pediatrics, and we saw really good improvement results on pre and post test, which is one of the metrics we use, as well as positive evaluations. The ongoing plan, monthly champion meetings to really talk about strategy, lessons learned, and celebrate successes, representation on their alarm and technology committee, and continued metric evaluation. And I'm going to turn it back over to John now to talk about some case studies.
Thanks again, Lisa. So I do want to just give you guys some examples of things that have been done and some of the outcomes that we've seen. Now this is Augusta University Health and here in my home state, and you can see that they actually published on this last year. The title of their article was Team-Based Intervention to Reduce the Impact of Non-Actionable Alarms in an Adult Intensive Care Unit. And you can see Lisa, my colleague, was part of this team. And if you look at these bullet points, you'll see that they followed the model in a way, pretty much the way that we've shown it to you so far, including looking at their baseline data, implementing, implementing change, and then reviewing that data afterwards. And some of the data results that they were able to have, are right here. So, we've talked about non-actionable alarms and reducing, non-actionable alarms. And they did a comprehensive assessment along with us to help them identify some root causes and changes. And you can see they had a 32% reduction in non-actionable alarms. They reduced the amount of disruption, caused by those alarms. And they developed some new alarm management strategies, for them to work with. And you can see that their Vice President, Chief Medical Officer, Dr. Delsberger, said that their results were substantial. It's so quiet. We look forward to continuing to move forward in our quest for a quieter work environment. I mean, that's some great work that was done, by that team, even with our help, but really done by, their own staff team. This was a large, integrated delivery network, and we were looking at alarms, like I said, across the continuum in this particular case. Yes, we were looking at monitoring alarms, but we were also looking at IV pump alarms and nurse call notifications. This group, when we put this together, we actually used that Cocreate model that Lisa just talked about. This was actually done at multiple hospitals on multiple different units, and we implemented or helped them implement pilot programs, based on what the teams felt or prioritized, in those individual areas. And one of the things that we learned there was that their PCTs or their care techs, were the first receivers for multiple alarm and alert notifications, from the nurse call system, it wasn't standardized, and some of them were not necessarily appropriate. This was going back and looking at those alerts and deciding who should get what. And in this particular case, at one of those sites, this actually floated, to be a top concern. And so we mapped their process and we looked at their, nurse call notification. And so if the patient did an alert, what would happen is the primary PCT, as you can see there, would get the alert no matter what it was. And then it would also, this particular unit was broken into 3 pods. And all 3 of those pods would alert at the desk from that alert. Now, if the PCT didn't respond within 2 minutes, it would go to the primary RN. And if that primary nurse didn't respond in 2 minutes, it would then go to the charge nurse, and it would also loop back to that primary PCT while those, stations on each pod were continuing to alert. The amount of noise that this created was kind of amazing to me, quite frankly. So as we looked at this, one of the things we did was really kind of dig down into who needs to get what alerts are going to go where, and we changed the way that their escalation process worked. This is what we piloted. And so no consoles received the initial alert, as we looked at these, unless it was an emergency alert. We added a second PCT, and the team decided that they wanted those alerts to be silenced in the room so they were sure somebody saw the patient. We also disabled some alerts that were automated that were actually, we had found were not actually helpful, and actually had a pretty high false alert notification. So as you can see, what happens now is the patient would press the button, the primary PCT would get the alert. They knew that they had 2 minutes to respond to that alert. If they didn't, now that 2-minute delay, it would go to the secondary PCT in that unit, and it would also go to the primary RN, and it would go to the pod where that room was assigned. So if the room was in pod A, the pod A desk system would also alert. Another 2 minutes, again, it would go back to the chart. It would go to the charge nurse, just like you saw before. It would also trigger the other 2 pods desk alerts, and it would go back to the primary PCT. So what do we get from all this? Well, what we got from all this was a couple of things. We saw a change in we saw a reduction in their audible nurse call alerts of almost 8,000. And we also saw a change over time in their HCAP score, which generally is a lagging indicator, but we actually went out a few months to look at this, and they saw their call light response go from 64% to 78.9%, and their help to toilet question on HCAPs went from 61.9 to 80%. So we had made some positive impact, and they continued to move forward with that and looked at, whether they needed to pull that across the house. So this is another noise study, and this was done by Jill Lay, and you can see they were looking at patient satisfaction scores in this case as well, and you can see, as they implemented their system, where their project implementation was. You can see down here is they were at 54.7. So they implemented their improvement project to reduce noise, and you can see over time their HCAP scores came up significantly on this question to 76.7. Another area where we had done some work was in central monitoring units, and this is a quote from one of the folks that I was able to work with at Huntsville Hospital, and Wendy Cantrell was the telemetry monitoring manager, and she was key to this. But one of the things that she said when they were done was the noise level was overwhelming to the technicians, and the work that we were able to do there, they were able to notice it right away, and it made for a healthier and safer work environment. So these are other results and outcomes from a few other places that we've seen, 37% reduction in alarms, and that equates to 155, 1,000 alarms plus a little. 61% reduction in alarms, by helping them with some electrode changes. All right, approximately 10,000 hours of non-value-added work eliminated. That's a huge thing when you start talking about non-actionable alarms, the amount of work hours that a nurse puts into that. 29% reduction in IV pump alarms, and here's the big one down in the corner in that blue box. In all of these things that we've done, we've seen no adverse patient events and no near-miss events. And it's one of the things that we monitor in every pilot that we do, because, of course, we want to make sure that we're not adding any risk to the patient as we try to make these improvements. Here's some other strategies that are out there for noise reduction, and these go well beyond alarm and alerts. And that first column really can be done anywhere. Quiet hours, limiting overhead paging, routine maintenance. One of the loudest things that we hear in some places that we go is sanitary carts, restock carts, and some of those things can be quieted down, with some simple, with some simple lubrication. Sound reducing curtains and tiles, I get a question a lot, when people are in, procedure areas or in emergency departments where I have a lot of background, where they might have a vertical zone, how do you reduce sound there? There are some great tools out there in sound reducing curtains that can be used, monitoring for, clinical need based on guidelines. Does everybody need, telemetry? Does everybody need a monitor? Got a whole nother webinar on that, but that of course reduces the amount of noise as well. And then some positive sounds in your soundscape, exploring your soundscape beyond just negative noise, but some background music, fountains. And then of course when you're remodeling or building, that's a whole, that presents a whole different opportunity, to install some white noise, looking at private rooms, the location of things that make a lot of noise, elevators, ice machines, things along that line. Those can all be pulled in there. So, and then looking at a bundled strategy to reduce noise, this was some work that was done at University of Rochester Medical Center, and they didn't pilot just one thing. They were piloting a number of different things. They called it their noise reduction bundle, and you can see the things there that they worked on, and you can see that they had a reduction in noise, over the period where they were working. So it doesn't have to be just one item. You just have to know what those data points are that we're looking at and how we can isolate them. Lisa, I'll let you wrap it up with some long-term considerations.
Thank you. And we're back to this picture again. We've spent a lot of time talking about reducing noise, but just as a reminder, we're really looking at effectively managing sound. So if you can identify some quick wins in terms of reducing noise, you can also start focusing on some of these other areas. And we do get sound measurements, and we are looking at peaks, but one of the things you also want to try and get is really sound measurement related to ambient noise or the background noise that exists in a room, in a unit, because that essentially provides good information for you. First off, if you're trying to hit that 45 decibel number during the day, it's good to know where you are in terms of background noise to begin with. If you're at 35, you've got some wiggle room, but if you're already at 50 because the air conditioning vent is loud for some reason, then you will not be able to hit that. You also want to have that baseline because you have to find the balance between too little baseline sound, ambient noise, because then your peaks are more noticeable when a sound goes off. It's like being in a library where it's very quiet and somebody's phone rings or they drop a book. And it's the same thing for HIPAA compliance, but in the other direction. You want to have enough ambient sound to help muffle when you're having private conversations with patients. So again, those are the things to think about. And I'll leave you with this thought. It's old, but I like the quote The sense of hearing cannot be closed off at will. There are no earlids. So when we go to sleep, our perception of sound is the last door to be closed and also the first to open when we awaken. So something to keep in mind as we take care of our patients and also take care of ourselves. And thank you. That is the end of the presentation, and now we're ready to take questions.
Thank you so much, Lisa John, for that very insightful presentation. Just as a reminder for the folks in the audience, if you do have questions, there's the Q&A panel on the right-hand side of your screen, so please submit your questions there, and we'll try and get to as many as we can. Our first question is a look-ahead question. There are new options on the horizon to replace the in-room bells of monitors and monotonous patient-to-staff requests. I guess the question, are there new options on the horizon to replace the in-room bells of monitors and monotonous patient-to-staff requests?
So, yes, and you'll hear a lot, I think, about the silent hospital or the silent ICU, or you may hear both. And I think vendors across the board are really looking at how do we ensure the appropriate notifications are the ones that are coming across in the first place. And second, how do we ensure they're more at the point where the care provider is versus in the patient rooms. So things are being looked at where you don't have the alarm actually going off in a patient room. You just have it going to the appropriate staff, but yet also having the ability, if you're going in the room, to turn the alarms on so you capture them as you're there. It's also trying to limit the alarms that are available. I can say from a patient monitoring perspective, you know, we went from pretty much your life-threatening alarms, which were about 5, to almost every arrhythmia alarm you could imagine that generated more alarms. We're now circling back and going, you don't necessarily need to get an alarm for all of those as long as that's captured some other way. So things are on the horizon. I still think we have a ways to go, but it is definitely an area that I think, again, any vendor is really focused on.
Great. We have another question here about kind of fitting older facilities. So I'm sure a question many in our group here are pondering as well. So the question is, our facility is built in the 1950s with some add-ons in the 1970s. Approximately 50% of the rooms are 2 bedrooms. How do you manage these types of double rooms and noise is the question.
I can go ahead and take that. Go ahead. I was going to say, John, I think you covered some of this, actually.
Well, I did, and I'm sorry. I was trying to pull off a mute there for a second. And it's interesting because in my life before Phillips, I worked in a facility very much like what's being described there. And, you know, I did mention a few of those things. You know, that's very true. Sound dampening curtains are one of the first things that come to mind, especially if you're, you know, in double rooms. Other things that kind of fit in there, you can improve that soundscape with some, you know, we come back to that positive noise, some white noise, that kind of thing can be brought into those locations. And monitoring, taking that room and checking those sound levels, you know, for TVs and, you know, now you got 2 TVs going in the room, things along that line, and making sure that you adjust from a facilities perspective, you know, so that we're not doing battle between the 2 beds, can be helpful as well.
Sure. Thank you for that double click on that one, John. Another question we have here is there a scale for measuring hearing and loudness of sound, similar to the long Baker scale that we have for measuring a person's, you know, pain scale?
So you can certainly get sound measurements. The challenge becomes perception. So can we get loudness? We absolutely can. Are there guidelines? There are, as we said, 45 decibels during the day, typically 35 decibels during the night. There are guidelines in terms of safety standards and how much decibels you should be exposed to. For instance, I think it's around 85 decibels is considered the safe maximum number for noise exposure without ear protection over an 8-hour shift. I'll have to double check that, but I think it's around that. So there are guidelines like that, but as far as perception, it gets difficult. And we laugh in my family because when my husband and I used to first go stay with his parents, we'd be in the bedroom and they had a clock in there that I couldn't sleep. I heard the ticking and it absolutely drove me crazy, a psychological impact. My husband didn't even notice it, and his family didn't either. And so they always laughed because they did learn to take the clock out of the room when I was coming. And that's part of the challenge. It is different for everybody, but I think what we can do is incorporate it into our assessments. So it could be something, as you're talking about pain, where you are talking about, you know, how are you feeling in terms of noise and what's happening, and are there particular noises that are upsetting you? And that should also be part of the patient and family education to really talk about that too, so that they're comfortable coming back and saying, you know, it seems like the alarm's going off all the time. Is there any way it can be changed? Or, gosh, we hear the ice machine every time. Could we possibly change our room? Not easy, I know, but having those conversations too. But I'll double check again, but to the best of my knowledge, there is nothing out there.
Thank you, Lisa, for that. It doesn't look like we have any more questions in the queue, so I think we can wrap up a couple minutes early here. Just want to remind everyone that the session was recorded. We will be sharing the recording. You will get a notification once we have that ready and available. And looks like we'll give you a few minutes back here before your next meeting. Thanks, everybody, for joining, and have a good rest of your day.
This concludes today's webinar. Thank you for your participation. You may disconnect your phone lines, log off the webinar, and have a great day.